We have to switch slides. Well, thank you for the opportunity to visit with you this morning and share some interesting findings. You know, my team, my Penn State team, has been working for some time with a large aging cohort of rural older Pennsylvanians, and we focused a lot on obesity and adverse functional outcomes, nutrition in relation to adverse health and functional outcomes, and healthcare resource use. But what I want to do this morning is we're going to wade into an area of just tremendous controversy, and those of you that know me I love to do that. So we should have some fun with this. I suspect it'll evoke some interesting discussion. So we're going to talk a little bit about health outcomes associated with obesity and overweight and aging, really focus on mortality outcomes, and then explicitly on the so-called obesity paradox, and in particular about what some of these findings might mean and where we would go from here. You know, when I first started some of our aging studies, I was seeing patients like this in clinic, and we published some of our first studies on obesity and aging really early in the 1990s, and at the time, you know, we really couldn't get the time of day. The focus was really on frailty, undernutrition, tiny, functionally impaired older persons. But of course now you go on rounds in any hospital, intensive care unit, chronic care facility, you actually will still encounter some of the tiny, frail older people, but you also will encounter many older, frail, overweight, obese persons. So there's lots of adverse outcomes related to obesity as one ages. I mean, I sometimes think you're born, you start to have inflammation, and then it progresses the rest of your life. But premature disease, functional decline, duration of life, the earliest studies that did not show a relationship are really confounded by important covariates, including smoking. I think it's safe to say that in general, obesity does not generally confer health benefits, and everyone's familiar with sort of the classic J-shaped mortality curve in relation to BMI, and I'm going to show you some of those where mortality is increased at either end of the spectrum. Obesity is strongly associated with all-cause mortality, but here's a key observation for which there really is a wealth of data now, and that is that it is a much stronger predictor at younger ages than older ages. And it is, you know, if you acquire obesity as a child or young adult, it's clearly associated with decreased life expectancy. And I don't want to dwell on this. I mean, everybody in this audience would be quite familiar with just the host of medical comorbidities that go with obesity, you know, including obviously cardiovascular disease, diabetes, metabolic syndrome, a host of malignancies, and so on. But as I said, what I wanted to dwell on this morning was the obesity paradox. And really for quite some time, really more than a decade, there has been a growing literature looking at this question. A very nice review article here by Oreopoulos, that in the elderly, overweight and mild obesity is associated with lower, not higher, mortality risk. And of course, people will often ask, well, why could that be? And we don't really have all the answers, but some of what I will share with you today may begin to address some of them. And of course, naively, we've sort of said, well, it's that if you're somewhat overweight, it'll give you a metabolic reserve to survive illness or injury. And of course, there may be something to that. And I want to share really what was a landmark paper by Kathy Flegel in JAMA in 2013, where he looked at the association of all-cause mortality with different BMI categories. And it was a huge systematic review and meta-analysis. When all was said and done, almost 2.9 million persons and 270,000 deaths. And the key finding was that, compared to desirable BMI, which in this case was defined as 18.5 to 24.9, that Class 2 and Class 3 obesity, so severe obesity, had significantly greater all-cause mortality, while Class 1 obesity was not associated with mortality, and overweight was actually associated with significantly lower mortality. So some of that is shown right here, and I've actually, whoops, didn't mean to do that. Come back. How do we get there? Good question. Get out of that. Come back. Well, it should come back. Yep, okay. There we go. I'm not going to touch it again. You can see there I've divided out age greater than 65. You can see the different BMI classes at the top of the column headings. And this is, hazard ratios with 95% confidence intervals. And if you look down, either it's measured BMI, self-reported BMI, and if you focus on the first column there of overweight BMI 25 to 29.9, you can see significantly lower all-cause mortality. And where you see it really start to go up the other direction is severe obesity up here at the other end, BMI 35 or greater. So this was quite the paper, and you would think this would have settled everything. Actually had the exact opposite effect, I think. If you want to read just a raging controversy, go take a look at this editorial in Nature in 2013. People tend to feel very passionately about the so-called obesity paradox one way or the other. And I understand that. Of course, what I'd like to do is bring some really robust analysis to this. I would say one of the key issues that did come out of this discussion that I'm really very much supportive of is how do we best interpret these kinds of findings for health professionals and for the public, which is a key challenge before us. This is from one of David Allison's review articles, but this is just showing you data that the lowest mortality in a J-shaped curve shifts towards higher BMI for older persons. Now, I did want to touch on sarcopenic obesity because this is potentially one of the key issues here. This is actually work we did doing MRIs on thighs in obese and overweight older women scheduled for knee replacement surgery. And of course, not only is sarcopenic obesity associated to some degree with decreased muscle mass, but a lot of issues now around poor muscle quality, poor muscle function. But the lower right panel here shows that the white is fat, and you can see muscle heavily infiltrated with fat, abundant subcutaneous fat. And one of the key issues around benefits or lack of benefits of being somewhat overweight or mildly obese likely are significantly impacted by body composition. So I'll share a couple of studies that actually my colleague Tammy Harris first brought to my attention. And one of the key ones is right here by Murphy from 2014. It's a modest-sized aging cohort. They all had thigh muscle by CT scan. These folks also had diabetes. But the interesting thing was the highest mortality was among those with low muscle mass who were either normal or overweight, okay? And normal weight participants had elevated mortality risk compared to those who were overweight, and this apparent paradox appeared to be partly mediated by muscle mass. So quite interesting. And I wish it was just that simple. Because this is another one. Looking at BMI, body composition, and mortality outcomes. Large study by Bay and authors just last year, all of whom underwent DEXA. And high BMI was associated with increased mortality, while total body fat and lean body mass were not for overall. But if you looked at women, those 50 to 59 who had greater total body fat had increased mortality, and those who had greater lean body mass had decreased mortality. But ready for the last bullet here, these findings were actually reversed for women who were even older. So, I mean, we're looking at a pretty complex scenario here. So we're talking about body composition, gender, age, all being potential factors, let alone the population being studied. So what I want to share with you is our attempt to bring some rigor to this discussion. And this is data that my last presentation about 6 months ago I couldn't share because it just now has come in press. So I'll share with you some new observations. And this comes from work with my Penn State team. Fion Cheng was a fantastic doctoral student, and Zhang Gao was a Penn State nutrition epidemiologist working with us. And this comes out of our Pennsylvania cohort, about 4,500 older people. But note these people are old. So baseline age, 74 years. So start with the premise there's a significant selection bias. These people are survivors, which of course makes them interesting to study. I mean, what's left of my large aging cohort in Pennsylvania now is about 2,500 people, all well over 80. We've got a bunch of centenarians, and this was out of 22,000 people we started with 20 years ago. So anyway, baseline age 74, baseline BMI mean 29.5, so they're overweight and mildly obese to begin with. And we followed this particular subsample for a mean of almost 11 years. And we're looking at 3 models here. One was adjusted for age and sex. Model 2 was that plus smoking status and alcohol use. And model 3 was all of the above plus the kitchen sink. Okay, so we're really trying to control for everything that we could think of. So you've got disease burden there, labs, medications. And this is a table summarizing all-cause mortality in relation to BMI. I neglected to mention on that prior slide, this work is e-published in Obesity. It's literally just coming out if you're looking for it. So this is all-cause mortality in relation to BMI. Again, reference BMI 18.5 to 24.9, hazard ratios and 95% confidence intervals. And one, look over there on the underweight side, less than 18.5, that's bad, all right? That makes sense. Usually going to be associated with significant underlying disease in this setting. But look at overweight and mildly obese in these models, significantly lower than the reference range. On the other hand, similar to what you saw from Dr. Fliegel's work, at the higher end, you see the hazard ratios going back up. Right? That all makes sense. So looking at this paper, one, we do find the sort of J-U-shaped relationship between BMI as a continuous variable and all-cause mortality, adjusting for everything we could get our hands on. Those with, at the low end, less than 18.5 had markedly greater risk of all-cause mortality. Those who were overweight or had class 1 obesity had significantly lower risk of all-cause mortality. And I'm not going to show you all the data, it would bore us to tears, but findings were consistent using propensity score weights and among never smokers with 2- and 5-year lag analyses and those with no identified chronic disease. So we really tried to bring a very robust approach to this. And this is just from that data relative to, in this case, to the BMI of 23, highlighted by this analysis. The lowest mortality risk was actually between a BMI of 28 and 30 in that sample. Well, we took this a step further, which is to look at the metabolic health status of these folks. And this paper also just coming out. And so it's the same cohort, same sample, same baseline age, categorized by BMI and the presence or absence of metabolic health using the Adult Treatment Panel 3 criteria. And we defined metabolically unhealthy as greater than or equal to 2 risk factors and use the covariates listed there. So age, sex, smoking, alcohol, metabolic labs, medications, and disease burden using a Charlson index. Now, Lord knows I'm not going to show you all this data, but I wanted to give you a feel for what we did here. These are all the sensitivity analyses that were run here. So we had a fully adjusted model with never smokers and no disease burden we looked at. We tried defining metabolically unhealthy to include all individuals with diabetes, whether they had any other criteria or not. We defined metabolically healthy to include only those with no risk factors as opposed to 2 and more. We ran analysis of never smokers, excluding all individuals who died during the first 5 years of follow-up, so a 5-year lag analysis. Ran an analysis excluding all of those who became metabolically unhealthy during the period of follow-up. All right? And then lastly, we looked at a variety of medications and ran those as exclusions, including cholesterol-lowering drugs, diabetes drugs, blood pressure medications. So we attempted to bring a high level of rigor to these analyses. So the results were, over 11 years, there were almost 2,300 deaths. Metabolically healthy overweight or obesity was associated with was not associated with significantly greater mortality risk. And this is key. And the findings were unchanged by all the exclusions tested in sensitivity analyses and by our propensity scoring. Now, an interesting tidbit, clinically I'd been convinced for ages in older people that diabetes was just so key. And it is. The association with BMI and mortality was more pronounced if you had a fasting blood glucose greater than 100 milligrams per deciliter and if you carried a diabetes diagnosis. So let's look at some of the data. So this is the proportion of metabolically healthy and unhealthy people by BMI class. So the pink bars are the metabolically unhealthy. So what you can see is the proportion of metabolic unhealthy people increases with greater BMI. And it's a relatively modest, by the time you get out to class 3 there, it's a pretty modest subset of people who are metabolically healthy. So makes sense. That's just the percents. Okay, so these are figures. I'm just going to show some of the multiple analyses, all right? I show you the hazard ratios and confidence intervals, and the actual numbers are to the right, but you can see the 1.0 there being the 1.0 hazard ratio, if you will, the reference. Divided by the different BMI classes, you little triangles and diamonds and squares, for all participants, metabolically healthy, metabolically unhealthy. Right? So you can see really quite dramatically the shift to the right signifying increased risk for metabolically unhealthy, across the board. So this is just the same analysis for no smokers with no identified chronic disease burden at all. And basically you get pretty similar findings, so it's divided into metabolically healthy, metabolically unhealthy by the criteria that were used. And then the last one I'll show you, because otherwise you'll get tired of seeing these, all right, is never smokers looking at mortality outcomes beyond 5 years. So it's a 5-year lag analysis. And you can see again, for the different BMIs, the hazard ratios, metabolically healthy, metabolically unhealthy, similar pattern. So the findings suggest there's a subset of pretty robust, healthy, overweight, and mildly obese older people. Now, I think an interesting hypothesis, and I know Tammy and I have talked about this to test, would be, are the metabolically healthy, overweight, and mildly obese people that we're identifying, are they also the same people who do not have inflammation and have relatively intact and functional lean body mass, which is just a really important hypothesis to test. So to summarize this, one, the metabolically healthy overweight or obesity was not associated with a significantly greater mortality risk than metabolically healthy desirable BMI. The so-called obesity paradox in previous studies may be partially, keyword partially, explained by the inclusion of metabolically healthy, overweight, and obese persons who do not have an elevated mortality risk. But in fact, of course, many of these people are metabolically unhealthy and have increased mortality risk. And based on very rigorous sensitivity analyses, our prospective cohort study showed that methodologic issues could not fully explain the obesity paradox. So, to wrap up right on time, talking about benefits versus risk here. One, I think it is safe to say that obesity does not generally confer mortality or health benefits. I do think that current use of the NIH BMI guidelines for older persons warrants reevaluation. I'm always horrified when I find in a chronic care facility where they're putting some frail older person who's moderately overweight or obese on a restrictive diet, for example. I think disease burden, we've shown, is likely a key issue. Body composition is likely a key factor as well. And elevated BMI may have no protective effect in the presence of reduced muscle mass and or robust inflammation. Obviously key factors are the population being studied, gender, age, body composition, disease burden. And I think coming back to one of the things I mentioned before, one of the absolutely key issues, since I do firmly believe these are very real findings, is how do we best interpret these for health professionals and for the public? The message can't be, everybody run out and eat whatever they want and don't move around, for example. And I thank you for your attention.